Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Ceramelli. I oversee Grand Rounds for our department. So today I'd like to say just a couple of things about our Grand Rounds series generally, and then I'll turn things over to Dr. Peel for an introduction of today's speaker. During today's presentation, I encourage you to write in any comments or questions into the chat or the Q&A. Either one's fine. I can look at both and keep track of questions or comments to go through those with the presenter at the end. There is a group of us that works on Grand Rounds throughout the academic year, including Semhar, Mike, and Charles on different aspects of the series. I'd like to acknowledge several sources of funding for the Grand Round series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, the Treatment of Mood Disorders Fund, and on some occasions, like today, certain divisions or centers within the department. With that, I think I'll just stop there, turn it over to Dr. Peel for today's introduction.
Great, thank you so much. I am delighted to introduce Dr. Brendel as this year's speaker for the Bruce Gage Lecture in Forensic Mental Health. This lecture is sponsored by the UW Center for Mental Health Policy and the Law to honor contributions of Dr. Bruce Gage. Dr. Gage was a local leader in forensic psychiatry. He had a profound impact on advancing services for persons with mental illness who are also involved in the criminal legal system. And also, he had a great contribution to educating the next generation of forensic mental health practitioners. Dr. Brendel exemplifies the ideals of this annual lecture. She is a clinical and forensic psychiatrist. She has too many positions and honors to do her justice here, but briefly, she is the director of the Master of Bioethics program and associate director of the Center for Bioethics at Harvard Medical School. She bases her clinical and forensic psychiatric practice at Massachusetts General Hospital, where she is the director of law and ethics at the Center of Law, Brain, and Behavior. Many of you are likely to recognize her name and contributions as the immediate past president of the American Psychiatric Association. Dr. Brendel has held numerous positions with the APA. She has also served as the president of the Academy of Consultation Liaison Psychiatry, and she is an appointed member of the American Medical Association Council on Ethical and Judicial Affairs. On a personal note, I have had a chance to know Dr. Brendel through our work with the AMA, and I have been so impressed by her breadth of knowledge, her thoughtful approach to answering difficult questions in our field, and her attention to education. I really want to thank Dr. Brendel for being with us today, and I'm so looking forward to your talk. I'll turn it over to you, Dr. Brendel.
Thank you so much, Jennifer, and thank you so much, Joe. It's really nice. It's great to be here amongst my CL family, my forensic family, and with all of you today. I'm just going to take a minute to pull up my slides. And I'm going to spend some time with you this afternoon talking about some of the work that we focused on, but really what's before all of us, regardless of what specialty and where we focus our practice, which is how we make sure that every American, and we'd like to take that globally, of course, that every person really has access to high quality mental health care at the right time, in the right place, and in an affordable manner. And so I'm going to be talking about that, but also today, in honor of Dr. Gage, really talking about some of the unique attributes of forensic psychiatrists and responsibilities of forensic psychiatry and how we might advance these ideas. So just by way of starting, I receive my income from Mass General Hospital and Harvard Medical School, and also some modest royalties and honoraria. I still sit as a member of the executive committee of the APA. I'm not compensated for that. As Dr. Peel told you, I am an appointed member of the American Medical Association Council on Ethical and Judicial Affairs, which I mention only because if I say something that gets me into trouble, it is most certainly my view and not that of the AMA, the APA, or anyone else. And I'm just completing, as of today, actually, a one-year term as a member of the Community Advisory Board for Osmind, which is a electronic medical record for mental health, for which I received stock options. All right, so none of this is surprising to any of you. We've been spending a lot of time now over the past year and a half or two hearing about how the COVID-19 pandemic left in its wake a second mental health pandemic. And so we've seen in particular adults suffering, and really a focus on the effects that the pandemic has had on our youth. So here on the East Coast, but we know it's no different than anywhere else in the country, really a shortage of available services for youth, and also adults finding it increasingly difficult to find services, as well as identifying the need for mental health care. This problem is not going to get better immediately. So the supply of adult psychiatrists is expected to decrease 20% by 2030, while the demand for services is expected to increase by 3%. And so estimates are that we'll have a shortage of more than 12,000 fully trained psychiatrists within the next decade. We also don't entirely know whether this is a good estimate, because with the graying and aging of our population, it's also anticipated that the need for geriatric psychiatry will rise, and that's a bit unpredictable as of right now. There are some other things that pose challenges for how we can meet mental health needs in our workforce. So we have an uneven distribution of psychiatrists and other mental health specialists, and we generally have more mental health services available near population centers and academic medical institutions than in rural or less populous areas. The good news is that in 2022, we saw the most GME slots filled for psychiatry. So 99% of slots filled in the match. That's over 2,000. And we've also seen an increase since 2018 in the number of slots offered for psychiatry. I will talk a little bit about advocacy, one of the places that forensic psychiatrists can be particularly effective. But at the end of 2022, Congress funded an additional 100 GME slots, and still not enough. We also know that we have a lot of work to do in terms of funding the system with ensuring parity and coming up with models of care that pay for the cost of care. And the mental health pandemic has not been limited only to those who we serve. It's also really affected the workforce as well. So if you look at this survey of the mental health of frontline healthcare workers, you can see that 3 in 10 frontline healthcare workers either received mental health services or thought they needed them directly, but didn't get them during the pandemic. And some said they were too busy. We still see significant barriers in terms of acceptance of mental health as on par with physical health and needing treatment. So almost 1 in 5 being afraid or embarrassed to seek care. Affordability of care remains an issue, as well as demands in healthcare workplaces. And so just to see that 3/4 of frontline healthcare workers within the pandemic said that the pandemic negatively affected their mental health. And this hasn't gone away. So this report came out late last year from the CDC, showing that healthcare workers were facing serious mental health crisis, and talked about highlighting factors of burnout and harassment as being highly prevalent. So what the CDC report said was that at the end of 2022, so this is the data that came out late last year, healthcare workers in general were feeling burnout more often than before COVID-19, with increased symptoms of anxiety and depression topping symptom reports, sleep problems very prevalent, and also those who reported feeling harassment in the workplace had particularly high levels of symptoms. And when the CDC put this all together and looked at how this was affecting the healthcare workforce, what they found was that in compared to before the pandemic, the healthcare workforce in general is in a dire staffing crisis. So nearly half of healthcare workers reporting feeling burnt out often or very often. Increased job turnover intention. So we know that there was a major shift in in employment trends, people leaving jobs, starting new jobs, even leaving the workplace altogether. But that really began to stabilize by the end of 2022. And yet within the healthcare profession, job turnover intention, so the desire to leave a job or look for new career options actually continued to be up for healthcare workers. So that's another worrying sign about where we're going with all of this. And then, as I mentioned prior, the increase in perceived and reported harassment in the workplace is also associated with increased odds of anxiety, depression, and burnout. Now, sometimes we say, well, this is frontline healthcare workers, and maybe this doesn't affect psychiatrists and mental health professionals the same way. And so our APA member data from a voluntary survey of which nearly 2,800 APA members responded from 2022 showed that 80% of psychiatrists responding had an Oldenburg burnout inventory score above 35. So what that shows above the orange line there is high risk for burnout. And we can also see that this is heavily affecting our younger graduates from medical school. So if you look at people beginning about 20 years ago who are solidly mid-career, the incidence of burnout is really quite high, or risk for burnout is quite high. And does this have clinical significance? Well, the same on a PHQ-9, the same respondents, 22% had a score above 10, right? So we know that that indicates moderate risk, but that's really quite significant, especially if we look at the implications for the workforce in terms of those who are solidly mid-career and in high productivity years. So what do we do about all of this, right? We see that we have a workforce problem. We see that we have increased demand and increased need by the public. And then we have this mission of our professional organization that tells us that our vision is to be the premier psychiatric organization that advances mental health as part of general health and well-being. So we're not doing particularly well amongst ourselves if 1 in 5 respondents is at moderate risk for depression, if we're seeing high rates of risk for burnout within our profession, and we're also seeing that within healthcare workers and the society at large, we have inadequate resources. And so when I became president of the APA, I really wanted to focus with the administration and the board on how we could meet our mission of promoting universal and equitable access to the highest quality care for all people affected by mental disorders, including substance use disorders, promote education and research, and advance and represent the profession while serving the professional needs of our members. And so as I sort of go into this and talk about some of the things that we do, I really want to highlight that forensic psychiatrists have unique skill sets that position us to lead. So in thinking about this and some of the take-home messages I want to instill in you today is that 3 areas that give forensic psychiatrists a particular I would say opportunity, but also responsibility to lead for the future of psychiatry, stem from familiarity with the legal system, the ability and skills and training and experience working within teams and systems, and then also really centering the margins and the marginalized, the unique experiences that forensic psychiatrists, especially those who work in the criminal legal system, have to be able to give voice to those who are often neglected or forgotten. So I'm going to start with the unique skills of knowledge, skills, and attitudes of psychiatrists within the legal system, because one of the critical ways that we can advance psychiatry for the future is through advocacy. And so the familiarity with the law, the experience working in legal systems, and even just experience with testifying in court, understanding how to appear before either a tribunal or a jury or a fact finder, and also having to speak in public, right? So speaking in legal spaces is a particular kind of public speaking that many psychiatrists don't have experience with. And so these skills really can put psychiatrists, forensic psychiatrists, in a place to be agents of change. And so here are some of the examples of those skills in action during my presidency, but just to also show you how in order to implement change, we have so many different areas that we need to influence. We need to educate the public, which we can do through media of all different sorts. So our post-pandemic, as you know, Boston is a pretty big medical town. And so during the pandemic, we had physicians on the local news stations talking about public health, talking about COVID-19. And as the need for that information started subsiding, our local news stations engaged psychiatrists to provide regular information to the public about mental health. That's one way we can help advance mental health and help people get treatment and fight people's reluctance or shame or concern about seeking mental health treatment. Also, a lot of opportunities with White House recognition in 2022 of a national mental health crisis. So both a challenge, but an opportunity to be involved in advocacy and policy. And then an opportunity in the bottom left, this was virtual testimony before the House Committee on Energy and Commerce. But there were 4 experts. 3 of them were psychiatrists, members of the APA, and 2 of them forensic psychiatrists. So I testified on behalf of APA, and we also had Deborah Peinels, the past president of Apple and the current medical director of Apple, who testified on behalf of the state mental health programs. And so this advocacy came together. It took consistent work, chipping away at the block, really being in public, putting forth our agenda, working with our administration and our federal and state advocacy teams. But at the very end of December in 2022, Congress passed the Consolidated Appropriations Act of 2023 that had significant funding of critical mental health and substance use disorder programs. And also supported a number of APA legislative priorities, including bills that were sponsored and advanced by the APA. So I told you already about the 100 psychiatry match slots across psychiatry and its subspecialties by 2026. Funding and support for the collaborative care model, right? Something so important, UW has been so important in advancing and researching and making available. This led to block grants to states for primary care and pediatrics practices to adopt the collaborative care model. I'll say a little bit about it, though I have to say I'm a little self-conscious coming to the mecca of collaborative care and thinking that I really have anything to say when I ought to be listening. Legislation, which we now know the postscript of, to extend and now even make permanent telehealth flexibility around metrics that had made it hard to implement telehealth programs and make mental health services available to patients. We know, for example, that the site of origin now for Medicare, which required a patient to be seen on site in person, is no longer required. We just saw in the past few days an extension of buprenorphine prescribing by telehealth as well. So some really significant reduction in barriers to making mental health and substance use treatment available. to Americans. Enforcement of parity. So really important provisions that close loopholes for state and local government health plans in terms of ensuring that mental health was beneficiaries and health plans had access to mental health services on par and funded on par with physical other health conditions. And then also to ensure the diversity and preparedness of our workforce, APA was able to secure a reauthorization of the SAMHSA Minority Fellowship. And I think this is one thing that's really important, is that at a time when we're more polarized in our country, and we know that we see every day how polarized Congress is, it is possible to get bipartisan support for mental health. Even though it's hard to get bipartisan support for very much. So this is really, really a victory and a call to action for those of you with experience and interest in getting experience and being involved in the legal system to consider that broadly, right? It's not just about testifying in court or on specific cases, but taking those attitudes, skills, experience, and expertise on the road to influence lawmakers, to influence public opinion, and to really advance the cause for mental health. So a second way in which forensic psychiatrists actually, or others don't generally think about forensic psychiatrists, is people who are experts in working in teams and systems. And one of the things is that many of us in our training have experience working with medical teams, but forensic psychiatrists have quite particular skills working on teams and systems that are not just medical or health related, right? Some of these teams are actually non-medical teams. When we work, for example, with others in the legal system, when we consult or work in employment settings, when we work in administrative agencies. And so really working on teams and in systems in flexible ways across many, many different domains where there are multiple aims and loyalties is something that forensic psychiatrists learn to do and have skill at doing, and keeping a solution-focused mindset that both ensures the mental health and care for those who are in need, but also can meet the needs of systems. So most people think to correctional psychiatry or large public institutions when we think about forensic psychiatrists, but this happens for so many of us in the ways that we are integrated into workplaces to keep them safe, into wellness programs where we are responsible for helping staff as well as helping identified patients, and really thinking about how we do that to advance accessibility of care. Now, this is really, really important because this pie chart represents the disciplines providing care for psychiatry patients, and it's a setup. I think the answer is pretty obvious, but if you look at this and say, well, gee, of the whole entire mental health workforce, broadly construed, how many psychiatrists are there? Actually, not very many, only 6%. So is 6% of the whole pie of healthcare professionals providing mental health care to psychiatric patients. We are in a position that we have to work with others. It's an imperative. And we also have to think about, with our unique expertise, skills, experience, and knowledge, how do psychiatrists work in a way as team leaders, but also to ensure that the patients who are the sickest and the highest risk get the care that they need, and are able to be seen by those with the experience and skills to be able to address that. And another place where forensic psychiatrists can be especially helpful, this is something I talk about very much in my academic work at the intersection of forensic psychiatry and consultation liaison psychiatry. But skills in risk assessment and managing risk on teams is something that is really important that forensic psychiatrists can bring to solution-focused approach to the need for mental health. And so this is a word cloud that was done by the APA Board of Trustees. We've repeated it in a number of different settings at our Mental Health Services Conference, in resident groups. And really what leads when we ask what can psychiatrists do that other mental health professionals can't do, it's really leading around the medical needs of our patients, right? And so the difference when we ask trainees to look at this, In addition to medical, the really big words were involuntary commitment. So our trainees seeing particularly sick patients in the emergency room in need of care. But really remembering in all of this that our leadership needs to come from our medical skills and our ability to recognize risk and treat the sickest patients. Okay. So in order to bridge the divide between mental health and medical care, we know that mental health must be a part of overall health. And there are real ethical reasons that, and practical reasons we need to think about this. We know that patients with severe mental illness have a lower life expectancy than those who do not. And we also know that patients with mental health and substance use disorders are really cost intensive to take care of, right? So we have, if we want to think about how we make the pie of resources we have for mental and physical health reach the most people, we really need to think about ways that we can be cost effective and be outcomes and data driven in the way we're delivering care. We also know that patients with mental illness experience stigma and the challenges in access. We've highlighted those already. And then another piece of this that's really important to know is that even though we identify ourselves as psychiatrists, as the ones who provide mental health care, actually, a majority of treatment, about half to 60% of treatment for mental illness occurs in primary care settings, as opposed to only about a fifth occurring in specialty mental health settings. So this is something that's not new, of course, at UW, where you've been doing this work, integrating mental health care into primary care practices for a long time. But there are other things, right, that forensic psychiatrists are particularly good at, working in systems, right, that matters for this kind of work of figuring out how to get mental health care to patients in general, right? So when we think about some of the additional barriers to mental health care, when you look at these community primary care practices and community practices as well, you see that primary care physicians are less likely to have procedures for referrals, communication, and scheduling for responding to mental health substance use services than for other medical subspecialties. So it's easier to refer a patient. Primary care practices know what to do when a patient has diabetes or hypertension that needs specialty intervention. There are fewer systems and strategies and pathways when it comes to mental health. And coming up with and streamlining work within systems is something that forensic psychiatry could really say a lot about. And also thinking about models of reimbursement, time, and inefficiencies within health systems are additional obstacles. And so if we don't do something about these challenges, we're not going to be able to, with about at least half of mental health treatment happening in primary care settings, without addressing these structural barriers, we're not going to be able to make a dent. And so, as all of you know, I don't need to tell you, because of the importance of your institution to the development of the collaborative care model and research on the collaborative care model, but working together with a caseload-focused psychiatric consultation supported by a behavioral health care manager embedded in the primary care conference, a primary care practice can allow a single psychiatrist to be involved in the care of as many as 20, multiplier of about 20 in terms of the number of patients who can be covered with this measurement-based care, using care management and a consulting psychiatrist to augment the capacity of primary care practice. Another thing, actually, where forensic psychiatrists have been innovators long before the pandemic was in telepsychiatry. And so for a long time, forensic psychiatrists, especially correctional psychiatrists, have been involved in systems that use telepsychiatry to evaluate and treat individuals involved in the criminal legal system and in custody, who were in relatively remote areas where there would otherwise not have been access to mental health treatment. But going forward, telehealth has continued to open a vital pipeline to access for care. And while there was rapid adoption and growth by necessity during COVID-19, there have been some byproducts of this which have been particularly welcome in terms of drops in no-show rates, better treatment adherence, and high patient and clinician satisfaction. However, as we go forward, we're really going to need to look at is the ways in which telepsychiatry may or may not be as effective as care in person, how we balance and understand both the merits and some of the limitations, and think about the patients for whom telepsychiatry isn't working. So, you know, this is kind of where we are now at the beginning of 2024. But we also need to keep working to address and prepare for the future. And in this regard, if psychiatry doesn't take the lead, others will, and that may leave our unique skill set and ability to treat some of the sickest patients outside of systems of care. And at the same time, as 6% of the workforce, knowing that patients have complex needs and that teams of care, right, often work best to address the complex needs of those who we serve, we really, really need to think about where we go for the future, And so the roadmap for the future was my presidential initiative during the last year at APA. And what we charged our work group with was creating a roadmap of recommendation to lead the APA and psychiatry into the next decade. And so we asked a couple of questions, right, about how we could attain a society that has available, accessible, quality psychiatric diagnosis and treatment. And so some of the questions that we asked is, what will the future of psychiatry look like and require, how APA can advance that future, and what we would need to do to get there. And so I just want to really point out here that you wouldn't necessarily think that there are a number of forensic psychiatrists who would have been involved, right? We often think about forensic psychiatrists as doing evaluations or being in court all the time. But one of the reasons why this work group was so effective was that I was very fortunate that Bob Tressman, a forensic psychiatrist and psychologist, agreed to be the chair of the committee. And he brought with him many years of experience running the Connecticut Department of Corrections, running health for the Department of Corrections in Connecticut as a forensic psychiatrist, really bringing systems knowledge and expertise about care delivery that informed the work. And then you'll also see, I won't go through absolutely everyone here, but you see that Charles Dike, the current president of Apple, an expert himself, health director of the department also in Connecticut, and a leader in ethics, another critical member of this work group. Oh, and then I'll just give a really quick shout out to Marquita Wills, who will be APA's next CEO and medical director starting in June. On June 1st, we're delighted about that. And she was another participant in this work group. Okay, so what did this work group do? Well, they comprise strategic aims to establish and maintain APA as a thought, knowledge, and practice leader in mental illness diagnosis and treatment, and then to come up with ways in which APA's policy development and advocacy agenda could support these strategic aims going into the future. And part of this is around positioning APA, but really what it's in the interest of is how can APA advance psychiatry, and how can APA answer the call from those who it's our responsibility to serve. So this diagram is a little complicated, but really what it shows is what I just said in pictorial form, right? So we had 5 aims all surrounding the development of policy and advocacy. Look how big that circle is around all the policy and advocacy needs. And that's really a place where we're going to need to develop strength within forensic psychiatrists, people who can translate between the clinical and the public and the legal in order to help make this agenda come forward. All right, so let me just go through quickly the strategic aims. There were 5 areas where APA really identified needs to develop. One in psychiatric diagnosis, right? So the DSM is critical for the vitality of APA, but it also gives us a tool to be able to advance our research. And we know that as we develop our science, right, we can move away and begin to populate our phenomenologic diagnostic criteria with more and more evidence, data, and science to advance a valid, reliable, and usable tool as a foundation of psychiatric research, assessment, and treatment, right? So we're going at a pivotal place now as we move on from DSM-5 to DSM-6 about how we're going to respond to that call and how we're going to continue to advance the scientific basis of psychiatric diagnosis. And then we also need to think about how we do that across medical specialties, right? So we know from several slides ago that most of the mental health care is happening outside of specialty practices. And so how do we translate between our diagnostic categories in concert with our other medical and mental health colleagues? Another place really that we can think about how to advance psychiatry is through the development of clinical practice guidelines. And so it may also help us figure out how to get patients to the right mental health or medical clinician in the right place at the right time, right? So one of the things that APA and AMA together have been very concerned about our scope of practice around patient safety, right? So how do we ensure that those who are providing medical treatment to patients for mental health and physical health have the level of training that makes it safe for the patients? Now, it doesn't mean that everything should be done by psychiatrists. Quite to the contrary. I think in recognizing clinical practice guidelines and really getting data to drive this, we can also recognize the places that psychiatrists are particularly ineffective, and our colleagues in mental health and in medicine could be particularly effective, so that we use our resources wisely. And so real-time accessibility of data-driven clinical practice guidelines is one way that we can work together and recognize the unique skill sets and efficacy of our colleagues and ourselves in developing teams of care. And so one of the ways that APA is looking to do this is through the expansion of our PsycPro registry. And the idea of the registry is to collect broad swaths of data, not just about psychiatrists, but the registry also includes all disciplines that provide mental health treatment, and to develop outcomes data, not just process data, which oftentimes we talk about how many times we see a patient, but really looking at how we can be a leader in the data infrastructure needed to guide research into diagnosis and treatment. And having this data then can power algorithms and tools and models and our practice guidelines, as well as our training to advance the field. Moving along, the fourth part of the first strategic aim is really to develop quality measures and standards of care. So data from the registry can certainly help with this, but developing quality measures can help us ensure that we're providing the best possible care as well as value and values-driven care to those who we serve. And we can use our registry to test them. We can use the registry as well to inform the development of future iterations of DSM, and also to collaborate with our mental health and medical colleagues. And then finally, in order to do this, we have to really keep an eye on the kinds of education that both our trainees and new psychiatrists need, as well as those of us who have been in practice for some time and could benefit from an expansion in our thinking about the ways that we develop and deliver care and treatment. And so in thinking about education, what are the skills that the psychiatrist of the future will need? Certainly, right, I've made a very strong call for advocacy and development of systems and leading within systems that advance mental health, but that's not something that's necessarily taught across the board in residency programs and professional development programs. Okay, and then finally, right, with my tipping my hat yet again to the importance of policy and advocacy, we need to develop the structures and the systems that support our ability to deliver and fund mental health care. And so all of this work around quality, around diagnostic clarity, practice guidelines, education, data curation, and study can really help psychiatrists be leaders in this changing healthcare environment, and really help us move beyond treatment in the moment to addressing root causes and structural causes of health inequity that in particular affects those with mental illness. And so leveraging this data and this expertise can really help us in addressing root causes of social determinants, as well as achieving reform to sustain practices, attain parity, and ultimately what our goal is to do, expand access and advance equity so that every American has access to high quality, accessible, and affordable mental health care. So one more piece of this really then is thinking about social determinants of health, thinking about equity, thinking about structural solutions. I think forensic psychiatrists are often don't recognize the power and the position that they're in order to be able to center the margins and the marginalized and to really expand the umbrella around those who can and need advocacy within the mental health treatment space. And so the reason I say this and believe this is because of the prevalence of our participation in safety net and correctional systems and the criminal legal system in particular as forensic psychiatrists. And I want to really push everyone to use the opportunity to observe, right? We get busy and we go through our days and we become part of a system, but really to observe and inspire change in how we can affect these systems to bring treatment and care to those who really need it the most. So when we think about this, our observations about the prevalence of mental illness within the criminal legal system has led, for example, to the development of diversion programs and to providing treatment, right, as opposed to incarceration and other forms of custody. I'll also just say on this point, right, that one of the challenges, it's certainly better to have care within the legal system as opposed to no care. But what does it say about our society when the largest providers of mental health services are state and local, or county local correctional systems? We have a lot of work to do, and who better than those who understand those systems? I just want to highlight then in this vein some of the things that forensic psychiatrists and APA have already been doing, and also to highlight some opportunities for forensic psychiatrists in this space. So first, the Judges and Psychiatrists Leadership Initiative is something that APA has been critically involved in, and it's a collaboration between psychiatrists and judges to train the judiciary and individuals in the legal system about mental health and mental health resources. So the Judges and Psychiatrists Leadership Initiative, one of the leaders of this is forensic psychiatrist from Hawaii, Michael Champion, very much involved in strategic planning meetings with state governments, Justice Center, National Centers for State Courts, really working in all the places that we can influence policy and think about care and advancing mental health. And so the goal is over the next decade, you remember the next decade, we're going to have a shortage of 12,000 psychiatrists. But the JPLI is committed to training 10,000 judges and 2,500 psychiatrists to improve knowledge about and options for mental health treatment through train the trainer events and collaboration on state-of-the-art, up-to-date treatment. And so just looking at what something like this can accomplish over the first 10 years of this program, it trained over 1,300 judges in 23 states in the District of Columbia. So hoping by 2030 to reach every state. Virtual training has also advanced the ability to be able to reach judges and to bring collaborative solutions between the law and mental to advance, and psychiatrists to advance mental health. Also promoting national standards to improve court and community responses to mental illness. Thinking about how to approach competency to stand trial within the context of mental illness. And then the JPLI has also developed a newsletter that has over 4,000 active subscribers now, with a 1/4 to 1/3 open rate, which is quite high, showing how much the information in these newsletters and the impact of this collaboration has been. And so really looking forward, funded by the APA Foundation, the JPLI is really looking to expand, to build a community of judges and psychiatrists, and to increase the reach of our training so we can advance mental health within forensic, those who are forensically involved, in the hope of strengthening communities and community resources. And so just to highlight one final initiative, which is Stepping Up. But this is work that's been done in over 500 counties. You heard me mention that local correctional systems, justice systems, are the largest providers of mental health services in our country. So hundreds of counties have joined Stepping Up. It's an initiative to reduce the prevalence of mental illness in jails. And so if you can see the work that's being done, the goal is to increase the numbers of resources and tools, enroll more counties and innovator counties to come up with creative and collaborative solutions to reduce mental illness in correctional settings, and to do something to reduce the approximately 2 million people with serious mental illness who are admitted into jails every year. Okay, and so one really, really important number is that 47% of the US population now lives in a county where the Stepping Up initiative is active. And so we're on our way to really making a difference. So to summarize, and then I'll really look forward to your questions and comments about all of this, there are many challenges ahead for psychiatry and to getting mental health treatment to those who need it. We have a shortage of psychiatrists. We have challenges with access, and our remaining workforce is at risk from burnout as well. But there are also many opportunities, and in all of this, I hope that you'll see the incredible opportunities for forensic psychiatrists. I think forensic psychiatrists actually must lead because there's a responsibility with all the unique expertise and skills and experience within our forensic psychiatric community to be able to make incredible impact, right? It would be amazing to say 5 years from now, or even less, that all Americans live in a stepping up county where involvement with law enforcement doesn't have to lead to custody in a jail setting, but rather could lead to entry into a robust system of mental health care and treatment. So within some of these areas, of course, that forensic psychiatrists must lead are in advocacy, working within systems and teams, and also looking for opportunities to center the margins, to include and to bring care to those whose voices are often not heard, in particular those with criminal legal system involvement. And overall, there's a lot of work to be done. You saw we talked a little bit about APA's roadmap for the future. It's been unanimously approved by the Board of Trustees and is being implemented in the current budgeting cycle. But that's just one element of leadership for the future. Now, tomorrow, and down the line, we all have a particular responsibility to think about those who we serve and how we can advance the mental health of our country more broadly. And with that, I will stop and thank you for your attention and ask for questions.
Thank you, Dr. Brendel, for this presentation, for going through a considerable amount of effort and vision and strategy for psychiatrists, forensic psychiatrists specifically in leadership roles. I would like to encourage participants to write in any questions or comments. There are some questions that have come in. We have time to go through some. And I think, yeah, with that, I might just pose one of the questions that came in. It's a more recent question, but it follows up on something you had recently mentioned with data tracking, outcome monitoring, particularly through the APA, like you mentioned. Is there data, a way to track involuntary commitments throughout the country, state variation, effectiveness of this treatment model?
Well, that would be a great project to do. So I don't know. I mean, one of the biggest limitations in developing our ability to use data is to get decent data sets, right? So one of the challenge, I mean, there are a couple really big challenges, right? So if you compare psychiatry to cardiology, for example, right? In cardiology, we've got people's blood pressures, we have their resting heart rate, right? We have some hard data about their lipid levels and risks. In psychiatry, we have a lot of process data, how many times a patient was seen. We do have some routine screening that we do, but they're screening tools, right? They're not necessarily, they're not measures of effectiveness in broad scale. So I think one of the questions, right, that we really haven't answered all that well over time is not just for mental illness, but in particular for substance abuse, a big question: how much is involuntary treatment, how effective is involuntary treatment in the long term, right? So we know that we can stabilize systems, we can help people detox, but we don't, when people ask about this, it's the question that forensic psychiatrists really don't want to answer on the stand. We focus so much on immediate danger and immediate risk, which is important, right? That's such a critical part of our responsibility. But how do we build a system and get people to participate and collect the kind of data and data points that we need to really inform a more effective system? We've got a lot of work to do on that. Somebody's telling me that managed care organizations would have those data. Well, maybe, right? So it might be there. The question is, how can it be put together? And if that is the case, I think it's going to be really important to partner with payers. APA spends a lot of time working with payers on quality measures. Everybody wants them, because if we all have confidence in our quality measures and our outcome measures, then it puts us less at odds about what the evidence-based care must be for our patients. So if that data does exist somewhere, we will reach out to try to find ways to inform better treatment with that.
Thank you for that response. Dr. Peel, you're welcome to pose a question. Thank you for joining.
Great. Dr. Brendel, that was just such a wonderful talk. I appreciate so much your comments about advocacy. You know, I focus a lot on trying to get learners interested in advocacy as a way to learn about the legal system, particularly around legislative advocacy. And I'm wondering if you have any suggestions on how to get people maybe interested or involved in the process earlier, maybe in training or at earlier stages in their career.
Yep. So, you know, I have some cheeky kind of ideas, right? So like when I'm supervising or teaching and I get complaints, oh my gosh, like the system is so broken. We need to fix it, or we need funding, or we need to do something. You know, the voice of physicians and beyond physicians, right, to mental health professionals more broadly is so critical. Our lawmakers want to hear it, right? There are some, but there aren't a lot of us in state legislatures or in federal legislatures, and our voices need to be heard. So when we think about the systemic problems, really thinking about the ways, is there pending legislation? Can we write a letter to our congressman, right? So can we write a letter to our state legislators? And you know, especially within states, people think that so much has to happen in the level of Washington, but in reality, the majority of medical practice and mental health practice is regulated at a state and local level. And so really figuring out, I like to say, so like, who is your state representative, right? Who do you know? Who are you connected to? And actually get our trainees and our colleagues to, when you say something, do something, right? So there are lots of programs that make it really easy to email your lawmakers, come up with advocacy days, spend time going and meeting with people who can influence policy. Really, really important to empower ourselves, to empower those who we serve.
A related question, going maybe from national down to even more local. So someone asked about opportunities for leadership of forensic psychiatrists within hospitals or local health systems. What do you see as opportunities there?
Well, there are huge opportunities, right? So I think you know, one of the long before I got involved with big problems, I got involved with small problems, right, on the level of my institution. But those small problems were big problems in aggregate for the hospital, and for the people who were falling through the cracks in terms of being long length of stay patients in hospitals, not because of their medical needs, but because of psychosocial needs. And so if you know, I would say the way to get involved is, if you see a problem, think about what skills or who you know who could be able to come up with a collaborative approach. So, you know, one of the things that I had great job security because I became the end of the line psychiatrist. And when there was a problem in the hospital, I was involved in this consortium of care managers and physicians and administrators and social workers who were responsible for the long length of stay patients in the hospital. Nobody else wanted to take on these problems, right? So it worked out pretty well. But in that, we really developed both a specific set of skills and challenges for inpatient medical forensic psychiatrists and consult psychiatrists, as well as strategies to be able to work collaboratively with others in bringing those skills, teaching those skills, and advancing care.
Well, here we are, just approaching 1 o'clock. There were more questions and comments, and there is for some a sort of ongoing discussion afterwards, emphasizing interest among trainees. So Dr. Brendel, thank you for presenting the Bruce Gage lecture today in our Grand Round series. And thank you to Dr. Peel and others at the Center for Mental Health Policy and the Law for sponsoring the presentation, for organizing this, and for coordinating and inviting Dr. Brendel. So,
thank you so much for having me. It was a wonderful opportunity and good to see all of you.
Thank you, Dr. Brendel.